Hello, everyone, and welcome back to Echo Asthma Bootcamp. Today, we are going to talk about endotypes and biomarkers in severe asthma. My name is Ashley. I am your facilitator. I'm joined today by my coordinators, Rachel and Tabitha, and our wonderful hub team, Dr. Mandeep Jassal, Dr. Christian Hermanson, and Andrea Jensen, certified asthma educator. And now we will get started on our lecture from Dr. Care. This is on endotypes and biomarkers in severe asthma.
So in today's session, we'll talk about endotypes of severe asthma and biomarkers for severe asthma. So this is where we ended off the last session. The reason to recognize your patient's phenotype is to really attempt to use the phenotype to understand the underlying pathobiologic mechanism or the endotype that would then allow us to select appropriate treatment. And the way we do this in severe asthma is by using a biomarker. And so there are two main inflammatory pathways or endotypes that exist in severe asthma patients. There are two distinct pathways, type 2 pathway and the non-type 2 inflammatory pathway. And it's really important to differentiate between these two because as of mid-2020, biologic medications are approved only to target the type 2 pathway of asthma. And biomarkers can be often used to establish a baseline, guide an appropriate choice of treatment for these patients, and in some occasions monitor progress to see how they respond to the drug. Before we jump on to biomarkers, let's talk about inflammation in severe asthma. Type 2 inflammation is represented on the left side of the screen. Allergens and antigens is what often triggers the cascade. Thymic stromal lymphopoietin, or TSLP, is one of the early regulatory mediators that stimulate the Th2 cascade. The Th2 cell produces interleukins 4, 5, and 13. IL-4 triggers then the B cells to produce immunoglobulin E and ultimately triggers the mast cell for production of other substances downstream, such as histamine, leukotrienes, prostaglandins, and other interleukins. IL-5 is extremely important for eosinophil stimulation and sustenance. And a lot of the inflammation we see in type 2 asthma or type 2 inflammatory asthma is associated with this eosinophilic inflammation. On the right side of the screen is non-type 2 inflammation. This often gets triggered by exposures to irritants, pollutants, microbes such as bacteria or viruses that creates a series of downstream cascade that triggers the Th17 and the Th1 cells to produce additional molecules. Ultimately, the common pathway for both type 2 and non-type 2 inflammation triggers asthma and causes hyperresponsiveness, remodeling, a lot of mucus production, and smooth muscle hypertrophy or constriction, which is ultimately what happens in asthma to cause symptoms. What you see here are the different phenotypes and different inflammatory cascades. On the y-axis is the severity, and the x-axis is the age of onset. If you look at the bubble of type 2 asthma or Th2 asthma, these can be both mild asthma, such as exercise-induced bronchospasm, or it can be quite severe type 2 asthma, such as aspirin-related disease, late-onset eosinophilic asthma, or certain types of allergic asthma. Most non-type 2 asthma, however, tends to be adult onset and more likely to be associated with obesity. Late onset, particularly in women, can be associated with smoking, in which case it's more neutrophilic, as well as this concept of paucigranulocytic or non-inflammatory asthma. So let's review the main points about how to differentiate type 2 or Th2 high asthma from non-type 2 or Th2 low asthma. Type 2 asthma tends to have a lot of airway and systemic eosinophilia. They're often responsive to both inhaled and systemic corticosteroids. They're responsive to inhibitors of type 2 inflammation. And the predominant interleukins on this side are IL-4, IL-5, and IL-13. For non-type 2 asthma or Th2 low asthma, it's often represented by absence of airway and systemic eosinophilia. They may not be, or maybe less responsive to steroids. Currently, we do not have an FDA-approved drug available to manage patients with non-type 2 asthma. And these are the interleukins that are mainly associated with non-type 2 inflammation, such as IL-6, 17, 8, interferon, and TNF. And so these are some of the biomarkers that are currently available for helping manage our patients. Blood eosinophils is easy to get. You can routinely obtain a CBC with a differential count or specifically ask for blood eosinophil counts. It can be used to assess if your patient qualifies for anti-interleukin 5 treatment. And we'll talk about it at a later session. The limitation for this is that fasting, obesity, and adrenal activation can all fluctuate eosinophil counts. It's particularly important that when a patient is on chronic steroids or has been exposed to a recent course of systemic corticosteroids, that may actually mask eosinophil levels and needs to be considered when an eosinophil level is checked. Sputum eosinophils can be checked. These are not routinely checked in clinical practice because techniques are not necessarily standard. They're cumbersome, but certainly there are research studies and protocols that use sputum eosinophils routinely, and they can accurately predict response to inhaled corticosteroids. FeNO, fraction of excreted nitric oxide. These tests are easy to perform. They're often bedside or point of care tests, and they can track closely with sputum or blood eosinophils, and they represent airway eosinophilic inflammation. However, the American Thoracic Society FeNO-guided treatment algorithms have really not helped outperform symptom-guided plans. And then finally, immunoglobulin E. Again, a blood test can be used as a surrogate marker for atopy, and patients with high IgE can be identified to see if they would benefit from treatments such as omalizumab. These levels of IgE decrease with increased age, regardless of the patient's type 2 status, and levels usually poorly predict response rate to omalizumab, and usually we don't necessarily track these patients with IgE once a patient is started on omalizumab. So how do we put all this information together to really personalize the treatment for our patient with severe asthma? So this is the way I approach a patient with severe asthma. We do a dedicated phenotype evaluation, followed by a biomarker evaluation, and then we put the two together. So to review for a phenotype evaluation, you really want to get an appropriate asthma history. How old were they when they first started having asthma? Do they have a strong family history? How's their asthma control? Are they high healthcare utilizers, or is it well controlled? Do they have frequent exacerbations? What is it that triggers their symptoms or exacerbation? Is it allergies? Is it more infections? Is it more exercise? Is it aspirin? What is their exacerbation history? How many steroid bursts they get in the last year? How often have they gone to the emergency room? Have they ever had an intensive care unit admission? And then understanding what their comorbidities are around reflux disease, obesity, sinus disease, sleep apnea, recurrent respiratory tract infections, and then associating all this information with the spirometry. Do they have normal lung function, or do they have obstruction on their pulmonary function test? Do they have fixed obstruction on their pulmonary function test? And then once we know their phenotype, understanding what their biomarkers is to try and understand what is going on in their body and linking it to an endotype or a type of inflammation. This can be done with the help of an allergy test to see if they have a positive allergy test or allergic asthma, an immunoglobulin E or an eosinophil count check, and a FeNO may be checked as well. So once we have a phenotype and a biomarker, how do we put it together to identify treatments for our patients? So for patients with allergic phenotypes, these are patients who, again, to review from the last session, are early onset. They may develop asthma as a child or as a teen. They're often triggered by allergies, have a seasonal variation to their symptoms, and have a strong family history. For the biomarker evaluation, they will have a positive allergy test or some sort of allergen sensitivity and a high immunoglobulin E level. They may or may not have eosinophilia. And these are the patients who will respond well to omalizumab, which is an anti-IgE monoclonal antibody. For patients with eosinophilic asthma, these are late onset with a lot of comorbidities such as sinus disease, nasal polyposis, and aspirin sensitivity. They tend to have frequent exacerbations and healthcare utilization, and may even require oral corticosteroids for maintenance therapy. These are the patients who an eosinophil would be checked, and if it's elevated, whether it's in the blood or the sputum, would qualify for multiple drugs that are now available by the FDA, such as napolizumab, breslizumab, benralizumab, and dupilumab. Again, these are all the drugs that are available for patients with type 2 asthma, and we don't currently have an FDA-approved drug for patients with non-type 2 asthma. Thank you for listening and for your attention, and we'll open this up for Q&A.
All right. Thank you, everyone. Thank you, Dr. Care, as always. All righty. So, Dr. Jassel, what are our key takeaways from this lecture?
To re-emphasize what we talked about last week, because it was mentioned, of course, this week, is to differentiate phenotype versus endotype. So phenotype is pretty much everything you're going to see in a clinic setting. Your age, your gender, your triggers, things you're going to acquire from your history and your physical exam, as well as key laboratory workup that you can acquire, imaging that you can acquire, or lung function. The endotype is a little bit more specific. It is more talking about the disease mechanism. Is it type 2 or is it non-type 2? But for the purposes of most of the people on this on this call, it's about the phenotype and trying to really classify it. Now, when we talk about type 2 asthma, or this allergic or eosinophilic asthma, this is the one that's quite pertinent for us in terms of asthma in childhood. And of the cytokines or the inflammatory mechanisms that play a part, she mentioned specific types of interleukins. And if there's 3 that you should focus on, it's IL-4, IL-5, and IL-13. And IL-4 and 13 kind of go together, while IL-5 sort of is a standalone class unto itself. We also have those, impact downstream in IgE or an immunoglobulin E level as well too. Now, she said on multiple occasions, there is no FDA-approved medication for type 2 asthma, and that is true. There is one in advanced trial stages that looks very promising, but right now there is none. The reason why that is important is because we've all taken care of children with bad recurrent respiratory symptoms that seem consistent with asthma, and it's triggered by viruses. So in other words, they don't really have that large eosinophilic driven type of inflammation. It can just be bad recurrent viral attacks just causing problem after problem. Sometimes it can be pollution. But in general, for children, it is about allergic and eosinophilic asthma. For most severe asthma cases, we do see. Now, when she talked about how adults have that more mixed type of picture, eosinophilic, neutrophilic asthma, we in pediatrics have a little bit of that, but more often in the adolescent population of severe asthmatics, specifically those who sometimes are obese, who are perhaps smoking, or in other words, who have recurrent drug exposure, and those can be modified as well too. So it's questionable about the need for biologics versus other forms of lifestyle-based modifications that could help them, especially in these young ages. But when she talked about the phenotype biomarkers, and this is my final point I want to talk about, is she talked about 4 tests that you could do. One is serum eosinophils. That is easily acquired. You can do that through a simple blood test. Sputum eosinophils, I would never get, mainly because kids can't give you a good sputum sample at all. They'll just give you their spit. If you want anything from their respiratory tract, you might as well put a bronchoscopy. You might as well do a bronchoscopy, and there's not that many indications for doing a bronchoscopy for asthma. There is some, but usually no. Exhaled nitric oxide, she described it as a simple technique, and for adults or mature children it is, but for a lot of children it's very challenging because it involves you breathing out in a steady expiratory phase for around 10 seconds or so. So it's a kind of challenging test for very young kids. And the updated NIH December 2020 guidelines have stated that it is a nice additional test if available, if the other diagnostics are not elucidating the answers to your questions. So in other words, don't rely on it as your primary mechanism. And then the other biomarker, which is easily acquired too, is a serum biomarker, that being a total IgE level. So those were my big takeaways from that lecture.
But I was going to say that the adults trying to get a sputum eosinophil isn't really worth it either. You just get the spit, so it doesn't really matter what age they are. I don't do that one. You know, it struck me as this lecture was going on when she was talking about phenotypes and the biomarker slide, that asthma is not a 15-minute disease. You know, when we see patients for 15 minutes, 20 minutes, it's something that's going to take a while to elucidate some of this history, to try and get an idea of their exacerbations, their triggers, their treatment history, their smoking status. You know, this is something that's either going to be done at a longer visit if you can do that, or it's going to be a continuity of multiple visits to try and really get to the layers of the onion here. So it takes time and an investment to really get this level of control.
Thank you, Dr. Herm. Andrea, do you have anything you'd like to add to the key takeaways?
Yes, and one of the things that I always go back to is just that home assessment and thinking about what's going on in the home, and especially when you're trying to figure out the different endotypes here. Is there mold in the home? Are there dust mites? Are there pets? What's the heating like? Have they ever changed their furnace filter? There's so many things that go into that can really affect a lot of what's going on in the home, and that's the number one place to start. And I can't tell you, I will be so glad when I can get back into these homes, because as someone with allergies and asthma, I often pay the price. I often have an asthma attack, but the minute I walk into a home, I can either smell pet urine or smoke, or I can smell mold and mildew. I can smell something. So really making sure that you're looking into that environmental component is so important. So that will really help with their control and some of the other things we're looking at as well.
Thank you, Andrea. Do we have any questions from the group? Or Dr. Jassel, do you have any questions you'd like to pose to the group? We still have a little bit of time before our case.
Well, I'd be interested from the group if you guys have ever, when you have a patient with poorly controlled asthma, let's not just say severe asthma, we'll just say poorly controlled asthma, which likely is probably going to end up being severe asthma based on the medication. How many of you acquire laboratory workups on the first visit you see these patients, or do you ever acquire it? Do you just keep giving medication? I'm very interested to know, how long does it take before we start doing these workups?
Yeah, feel free, Dr. Nietzsche.
Hello. We in Germany, we would first look how the patient is going on, and I, as a pediatrician, don't believe that taking blood on the first session, if the patient is stable, is the best idea. But of course, as more as I can't, I don't have an idea what endotype or phenotype is working in this patient, I'll start to make more and more diagnostic. One question also, we're talking about eosinophilic blood. But of course, usually people come, or the children come and have already some steroid inhaled, maybe a small amount, maybe a big amount. And what occasion would you say that's still okay, so we can take blood? Or we better wait to, for a certain time that he hadn't had any steroids beforehand?
I think that's a great question. So to speak to your first point about how if someone is well controlled, how you should postpone the laboratory testing, I totally in alignment with you. I don't think there should be any rush to stick a needle in a child and cause undue pain if it's not going to change your management. If all we're going to do is just get lab work to help us feel better or to elucidate something, that's not going to help. But I probably, for me, and I don't know how it's like in the landscape of where you are in Europe, but a lot of caregivers and children, depending on their age, are very scared of the idea that they have to undergo regular shots. So I usually don't do it on the first visit, but I do talk to them that if I can get them under control with maybe 2 or 3 different tries of changing up their controller regimen, that this will be something we're going to do going down the road. So I prep them that the next time you see me, you're gonna probably end up seeing a needle by the end of the visit, just so they kind of get used to it, so they'll know it's coming at least. And then for your question about the CBC with the diff, this is something that I deal with on a weekly basis, because sometimes for example, we'll have our residents in our hospital, they'll order these CBCs with differential, thinking it's going to help us discern if they could use biologics, but they're already on systemic steroids at 2 per kilo, sometimes even higher. And so it doesn't help. So for me, if you are on a systemic steroid, either an acute or chronic basis, I don't get a CBC with a differential, because more often than not, I'm getting a falsely low value, because I can't tell you how many patients with severe asthma in status asthmaticus or having an acute exacerbation have 0 eosinophils, which falsely makes us believe they don't qualify for biologics. Now, in terms of your ICS, if they're on low, medium, or high, to me, it doesn't matter. I still get the CBC with a diff, because I figure that is their controller medication. That is what they're on a daily basis, or at least I hope they're on a daily basis. And if they're not well controlled on that maximum daily regimen, which should be used to improve their daily symptoms, their quality of life, that's when I want to check their eosinophils. And for you, I'll leave it up to you how you like your cutoffs. So for a lot of, for biologics, for example, the biologics we're going to discuss in more detail next week, but Dr. Karen, her lecture talked about it, was for the eosinophilic asthma, sometimes 150 is the number we kind of had ingrained in our head. But in my experience, and there's some studies to back this up, a number of 300 seems to be a little bit more helpful. I find I get a better response on therapies with a number of 300. Now, if you're talking about in IV forms, which is not approved for children, like reslizumab, if you're using reslizumab, then you need a much higher eosinophil level. I think it's around 450 or greater to really get a good response. But 300 is my number to make me feel like I can go to a parent and say, I think I'm going to make a difference here.
Thank you, Dr. Dasso. Thank you, Dr. Nishi, for your question. Do we have any other questions from the group? Let's see. Lisa, thank you, Lisa. I'm going to read this out loud for everyone. My apologies. Although non-type 2 risk includes smoking and usually teen population in peds, and we need to address this as a strong factor of symptom control, I also focus on environmental controls for all ages, all types of asthma, as the quality of air they breathe, inhaled irritants play a big role for children who are at the mercy of the air quality the adults in their life offer them. It's amazing to find out what some homes have as aerosolized, burning, or et cetera in the air that families don't connect to adding to symptoms. Thank you. Thank you, Lisa.
If I could just comment on that, Lisa, and I know that Herm and Andrea are way better at this than myself, and especially Herm because he sees adults. But for me, this, for a lot of my asthmatics, a lot of caregivers smoke cigarettes or smoke other products in front of their kids. And for me, it's this intergenerational transfer of not only smoke exposure, but smoking behaviors that is really challenging. And so I think you're bringing up a great point.
Yeah, I agree. Every week I'm dealing with somebody who says, well, I just smoke outside. Well, unless you smoke naked and shower after, and we have too many camera photos to let you do that, you just can't, bring it into the home. So I think the nice thing about family medicine is sometimes I can try and treat the mom or dad as I'm treating the child and say, well, let me try and work on your smoking cessation. I think this also contributes to a lot of polypharmacy because we keep escalating doses based on the response of the therapy, which isn't the therapy's fault, it's the environment. So I think that's a great point that Lisa brought up.
Do you know, and another thing, there's so many people vaping now and they don't consider that smoking because it's not smoking. And so we have to be very careful when we ask if there's anybody in the home that smokes or vapes, because we know that that can cause an asthma attack as well. And it can be quite a bit worse with the lung damage they're seeing with some of the people. So yeah, really hard not to, lecture. Of course, they know that they should quit. Just like when someone tells you you're fat, what? Really? I didn't know that. Thanks for that. But really working with these people and trying to, commiserate with them that we understand how hard it is. And I have siblings that smoke and they've been smoking for 30 years and have tried to quit multiple times. So I'm kind of trying to let them know that you're on their side, that if smoking is an issue, how can we help them with that? And most of the state health departments and the county health departments have the quit programs where they can provide patches, they can provide different things. And I know in our state, you can actually sign up as a provider and then you have direct access and you can put them in on that quit line and have someone contact them. But yeah, a lot of variables with that indoor air quality.
And I'd also just quickly add that don't think that vaping is just a high school problem or an adult problem. It's impressive to hear how many kids have exposure to vaping through the elementary schools.
Yeah, thank you, everyone. Oh, yeah, Lisa adds just sort of in addition, their sprays, cleaning fluids, which have seemingly been worsened through COVID, burning candles, cooking, that sort of thing. So it's very holistic in terms of everything that needs to be addressed. Thank you all. All right, well, we've reached sort of our halfway mark here. I think if we don't have any other questions, we can move on to our patient case. This will be presented by Dr. Jassel. All righty, Dr. Jassel, take it away.
This is a 15-year-old Hispanic female. She was born full term. There were no NICU requirements at birth. She did not have any oxygen needs. Her first symptoms that were consistent with asthma started a little bit later in life at around 6 to 8 years of age. The family was unaware if there was a viral trigger. She does have a cough. It is non-productive. The cough does not occur during sleep. She does have expiratory wheezing, she reports, and then she also has dyspnea as well too. She does respond to albuterol, but not always. She does report she does respond well to systemic steroid therapies, but it takes a little while. She says it sometimes takes 2 to 3 days till she finally sees some effect on therapy. As far as triggers, she reports multiple numbers of them in terms of upper respiratory tract infections, allergens, potential outdoor allergens. She said she's had some past testing, but unfortunately we didn't have it available at the time of the first clinic visit. She did report that exercise in general makes her very winded or short of breath. And she also reported that emotions also set off her asthma in terms of being angry or laughing or being excited. In terms of her controller regimen, she was using a smart form of therapy, which included 1 puff twice a day of Symbicort, and then an additional 1 to 2 puffs as needed. So she was getting up to a maximum of 12 puffs per day. And the family was reporting many days of reaching that maximum limit. She's also on Singulair once every night. Now, in the past, she had been on high-dose forms of Flovent, as well as high-dose forms of Advair Discus. In terms of medication adherence through the electronic health records, we did think that there was concern for medication adherence, but it is questionable given the inaccurate representation in our electronic records, but concern did arise. We can scroll down. And then in terms of her hospitalization, she's had 4 hospitalizations over her lifetime, 1 ICU requirement, but did not require intubation and did not require any non-invasive or let alone invasive positive pressure ventilation. She's had 5 ED visits in this year alone, and then she's had all of those ED visits. Every time they see her and they listen to her wheezing, they put her on steroids. Her last asthma control test, the ACT, was 7, and that was approximately 1 month prior to our visit. And then in terms of environmental exposures, there's quite a few. She's reported that she does smoke, at least used in the past. She's tried e-cigarettes 1 to 2 times in the past. She says she is not a current user. She does have secondhand smoke exposures from many visitors who smoke inside the home. And she reports third-hand smoke exposures, which could be derived from the second-hand smoke exposures, all occurring inside the home. In terms of the review of systems, we didn't really pick up on anything. She does have a family history of asthma. It's maternal, on the maternal side. Further down on the review of systems, we didn't get anything from an infectious standpoint. Now, she did not have any past history of anaphylactic episodes. Now, she did have her past asthma care delivered by another provider. Like I mentioned, the family didn't bring any of her past workup. But from what they said, she's allergic to everything, but they promised us she wasn't allergic to any types of food. She does have a history of allergic rhinitis and is on Zyrtec. She also has a history of, or suspected history of GERD, but not probably likely, based on having a little bit of chest discomfort after eating spicy meals. So I wouldn't get too excited by that one, but we are concerned about her obesity. She has a history of snoring with apnea episodes. She had a past sleep study that showed severe sleep apnea at a level of 30.2 events per hour. However, speaking once again to the compliance history, mom says she is not compliant with her prescribed BiPAP, and she did not bring that into the clinic visit. She has had a past history of an adenotonsillectomy as a toddler, so that sleep study was done after the adenotonsillectomy, many years after she had gained a lot of weight. She does have mild to moderate eczema on exam. There are no baseline, there are no other significant review of systems history. On her psychiatric history, we didn't notice any formal psychiatric diagnoses applied or any type of ongoing consultation, but the family did report she was frequently bullied in school, and she's missed several days from school due to asthma symptoms. And I mentioned the Zyrtec that she's on for allergic rhinitis I mentioned earlier. The family sometimes uses garlic supplements. A family member had recommended them to it, but they read about it online. In terms of the laboratory results, we're going to focus on the pertinent ones, and that being the eosinophil level, which is elevated. I mentioned to you the 300 cutoff. This one was at 310. She did have a venous blood gas. They got it during her hospitalization just because she needed some extra O2. I don't know exactly if it was fully indicated, but nevertheless, it wasn't too concerning. Her total IgE was 1,850, so quite elevated. She does not have any aspergillus antibodies. Her CRP is negative. Her SED rate and rheumatoid factors are not elevated, and her vitamin D level looked okay. Also, in terms of screening, she did not have any recent travel history since birth to any international location, so we weren't concerned about any parasites or anything like that. In terms of allergen history, she's allergic, like the mom said, to many, many things. So we confirmed that through our serum testing. We could scroll down. And then in terms of the diagnostic workup, her PFTs, now if you notice the timing of all of this, the last time it was done was right at the start of when the pandemic resulted in everything shutting down, but it did show combined moderate restrictive and an obstructive ventilatory defect. We did get some testing while she was being hospitalized, and it confirmed pretty much what we already knew already, that she has a lot of obstructive lung disease too. And that sleep study I already discussed to you about in terms of showing severe OSA. Now, her vitals on exam were notable for having normal saturations, but her weight was well above the 99th percentile. Her physical exam, if you could scroll down just a little bit, was showing inspiratory wheezing over the glottic region, so inspiratory wheezing. She did have expiratory wheezing as well too, that we heard all over her lung lobes, so both inspiratory and expiratory. So I guess the three big questions I had for this pretty complex kid with multiple morbidities, would her asthma phenotype indicate that she may be a candidate for biologics, and would you consider starting this option? What do you think about the poor compliance for the asthma control and the BiPAP usage? And is there any concern, or would it alter any of your workup knowing that she has inspiratory wheezing, especially over the glottic region on exam.
Thank you, Dr. Jassel. I'm going to add those questions into the chat so everyone can kind of take a look at them and form their answers for us. Alrighty, let us know what you think.
I'll take portion of question 2 regarding the BiPAP usage. And, you know, I don't have many adults that like to use their BiPAP, let alone, you know, children. So I would probably address that by trying to address the obesity problem, which is definitely worsened by all the steroids she's been on. And every time she has an exacerbation or goes to the ER, they probably give her more. But, you know, working with either Shape Down or other kind of pediatric obesity programs, trying to address diet and stuff. There's also, you know, to make sure the family is engaged in this, because if they're not really interested in making change, you know, I would try and address their smoking cessation as well, like we talked about earlier. But, you know, is this something that they are willing to commit to, or is this something that, you know, it really is not the time or place for them to think about this right now? But I think I addressed the sleep apnea through the method of treating obesity.
You know, I'm thinking of the inspiratory wheezing, and I'm wondering about the vocal cord dysfunction, especially given her age. We know it's really common among females, particularly, and those that that are doing exercise. And I know that they mentioned that's one of the things that happens with her exercise. And as far as the weight and the bullying, unfortunately, that she's using a lot of oral steroids. And I think once people understand the that you can use, say, Advair or something else for 100,000 days and get the same amount of medication as if you use prednisone for 4 days. They don't understand that disconnect. They think, well, I'm only on it for a few days, so I'm actually getting less medicine. And when they understand that their inhaled corticosteroid is going to go right to their lungs, which is where they need it, and the other one's going to go throughout their body. And not only that, as I know when my kids were little and frequently on steroids, they, you know, puff up and it causes a lot of weight gain. And that's really difficult to get rid of, that steroid weight. And so she's got a lot of strikes against her right now.
Do we have any suggestions from the group? Sure, go ahead.
I think even if she wasn't compliant or she had to take more steroids than others, I think we should give, and maybe the family is not helping so much. I don't know what things are behind. Sometimes I think because we have very good biologics, we should give always a try if we can get off steroids. I think you know, there are sometimes families, everything is working well and everybody is behind these children, and I think they shouldn't have more chance than others where it doesn't work like that. And we've got a system where we can give the biologics. I think we should try it if we can't find a different way.
Yeah, I think it's good to have that conversation with them and say, this is a potential option for you. I'd want to explore a little bit of, do you think you'd even come to the office every so often to get these injections? Do you think, you know, this is something that we're going to be able to deal with from an insurance standpoint? Because you're probably going to lay the groundwork, but you might not be able to get the approval or the engagement from a transportation standpoint right off the jump.
Yeah, I think Herm is, I'm in alignment with him too. Like, it'd be really interesting how you get biologics on Dr. Nietzsche in Germany. I'm sure it's a very different system. Here we always talk insurance. Insurance is our predominant language. But so for most of the insurances I deal with for biologics, they usually require about 80% compliance over 6 months. So if you think about that, that's 5 out of 6 months you have to pick up your medicine every single time. And it's an easy thing for insurances to see. And so if you don't meet that basic benchmark, you're getting an instant rejection. Now you can write very beautiful letters to talk about the emotional impact or the physical impact of all these steroids on this child. But no matter the emotional component you can add in terms of the language, they're still going to say, how come she can't take her medicine every day? Because you got to prove that at least to us for such an expensive drug regimen. And so it's one of those complicated things. So I'd love to hear how things work out in Germany. But and then also the other thing too that Herm is mentioning, administration is huge, because, you know, here I have found amongst pediatricians, we tend to be very conservative, and we stick with regimens we feel comfortable with. So omalizumab or Xolair has been around longer than any other. So we give it because we think we're so familiar with it, when there's other really, really good ones out there too that might be more appropriate. Now, we don't have good biomarkers to discern which one is the best, but right now, giving a clinic-based form of medication versus giving a home one. And I've been leaning more to home-based therapies for the ease of access for families, because they have to pay for parking sometimes to get to our clinic. So all of these are important factors.
Just to answer quick, I think we're lucky that usually we don't have to talk about the compliance. Of course, we as doctors have to think about it, but we don't have to tell the insurance. Of course, the indication always, all the things we need for indication have to be there. And of course, the medication had to be already in a higher standard with steroids, etc. That's, I think, similar. I think with the distance, maybe we have more doctors on a smaller area, so it's maybe easier to give them the possibility. I'm not sure.
Sounds like I'd have longer hair if practicing in Germany.
Thank you, Dr. Nietzsche. Let's see. We've got a thank you, Lisa. Lisa's unable to call in with us right now just because she's in a busy area. So I'm just going to read this out loud. That she would address the inspiratory wheezing as well. This can affect her own assessment of symptoms, as well as others who assess her in like an urgent setting. With her history, most would opt to treat the significant symptoms as asthma versus assessing for the VCD component. She's dealing with a lot, it seems, for a long time, and all of this can be hard to manage. We may need to add a referral for therapy to focus on stress, self-care, coping, and treatment adherence issues, etc. Thank you, Lisa.
Do you know, one thing I was thinking about with her VCD is, many people don't realize that you can have asthma and COPD. Sometimes you can have either or, sometimes you can have both. My daughter had both. And so really speech therapy is what she did. She was a competitive athlete, and it made a world of difference. And so if this gal that we're talking about is not able to exercise because she's having asthma symptoms and most likely also VCD, she's not going to be able to get that weight off from all the steroids, and then that's leading to bullying at school, and that's easier said than done for weight loss. But I think really looking at that to enable her to be able to exercise if she wants to, and not be so hesitant about that. And that's going to release some of those endorphins as well, and hopefully give us a little bit better outlet with her.
I think it's great that Lisa brought that up, especially with the self-care part, because there's a lot of kids, I feel, that don't believe that they're worthy of getting better. They don't have the self-confidence of their worth. And if we can try to invest in these kids to show them their worth, that might be the first step in being able to get compliance and exercise and all this other stuff addressed.
Thank you both.
Sorry, one more thing, Herm, and that's a great point, because I think if these kids realize that asthma is the most common chronic disease among kids, #1 cause of missed school days. So, they might not know about other kids in their school, but they're in good company. They're not alone. And so really helping them understand that. And if life ever gets back to normal, I know American Lung Association has some great workshops for the younger kids. There's Open Airways, which is a 6-week workshop. And then for some of the inner city kids that are more in the middle school or junior highs, they have something called Kickin' Asthma. And they come together, and it's 4 times, and they have little workshops and teach kids about dealing with their asthma and really managing that, and getting them really and they're meeting with other kids in the school that have asthma. And so knowing that they're not alone, and this is, it's pretty common. So that can be helpful too as well.
Thank you, Andrea. So many wonderful resources.
Don't feel you have to read that out. That's really
thank
long.
you.
So the gist is a lot of what we look at in the environmental assessment, and I'm happy to share what we do right now, since we're not able to do the assessments in person, is we send them homework. And so we have them look at all the areas of their home. How often are they vacuuming? Are they using a vacuum with the HEPA filter? Are they vacuuming under the kids' beds? there's a lot that they don't know. We have them check the MERV rating on their furnace filter. So that's something I'd be happy to share with everyone, since we can't go out and do assessments now with asthma home visits programs or Green and Healthy Homes Initiative. And then when I do virtual visits, they actually take their tablet around or their phone, and they can show me areas. They can show me the mold in their bathroom. They can show me the wet area around their toilets. So really helping them troubleshoot what's going on in their environment is really important. And I'm happy to share any resources that we use.
Thank you so much, Andrea. All right. Do we have any other suggestions for this patient or comments about treatment? All right. Well, then I will kick it back over to Dr. Jassel for his summary. Let us know how everything's going.
Yeah, so this is an adolescent female who has severe persistent asthma, who has environmental exposures, including tobacco smoke, in the home setting, who also seems like she has vocal cord dysfunction, obesity, severe obstructive sleep apnea, as well as a significant mental health history. So with all of that in mind, we tried to address as much as we could on that first visit. Now, the pandemic had impacted us on huge levels, but what we did was we told her to maintain her on her current therapy, but just try to stick with it and use the daily medication as much as possible. Because we really wanted to get a good assessment of where things were if she was going to take the medicine. And we tried to simplify it and to teach her. We emphasized the need for the BiPAP, and we got her, and we had a respiratory therapist go in the home and check the BiPAP, made sure it's working, made sure the mask and everything was working as well too. And we had our home asthma program come in for tobacco smoke exposures. I did refer her to speech therapy. She did not go, but I did refer her to speech therapy. And then we recommended follow-up after a couple months on therapy. What happened was she was lost to follow-up. She did not show up. But eventually we did connect 6 months later, after we had repeatedly kept calling the family to get an update, just because we were very concerned about her overall history and her multiple morbidities given her age and her social circumstances. What we found was her life was getting better, and we did not make much of an intervention. What probably ended up making a better life for her was the restrictions that COVID placed. Like so many kids who had improved asthma control during the time of COVID, she was one. By staying out of school, she was no longer being bullied. The stress of school had lifted. And now that school is back in session, I'd seen her not too long ago, the family said they are not sending her back to school, not because they're concerned about asthma or viruses or anything like that. They think she is doing better clinically, and she looks happier when she is not in in-person school. I don't know about her weight currently because everything was done via video visit, but the family says that they are trying to adopt a new lifestyle. They look happier, much happier than when I saw them in person in March of last year. So things got better, and I'd like to take credit, but I cannot take credit for this.
Thank you, Dr. Jasso. All right, well, I think now is a great time for us to move on to, yeah, great to hear the update. Very glad that she's doing better. All righty, well, let's scoot on to our post-test. Question 1, which of the following is the definition of an endotype? The external observable characteristic of an organism resulting from interaction between its genetic makeup and environmental influences, or a distinct biological mechanism that is underlying a distinct disease entity. And question 2, which of the following is not a biomarker for type 2 inflammation in asthma? Immunoglobulin E, IgE, eosinophil count, fractional exhaled NO, pheno, or interleukin 17? All right, I think we've got everyone. So I'm going to end this poll and share it. Okay, Dr. Jassel, how do we do?
We did good. The definition of an endotype is indeed, it's the mechanism. The phenotype is usually what we pay attention to in clinic because that's what we get when we do our tests or when we get a good history. And then which of the following is not a biomarker? Yes, the correct answer is IL-17. That's linked with type 2, while the rest, IgE, eosinophil, exhaled nitric oxide, that's all linked with type 2 or eosinophilic asthma.
Excellent, thank you. Thanks, everyone. And of course, everyone's favorite part. Do we have a volunteer for our patient presentation next week? Next week, we're going to be talking about biologic treatment options. It is a hefty presentation lecture, but it does not have to, your case does not have to align with the lecture content. Do we have any volunteers? Lisa, do you think that you would be able to present next week, or do you think a little bit later? Okay, excellent, excellent. Lisa just volunteered to present her patient case next week. We're so excited. Thank you so much. Can we get an echo clap for Lisa? Yeah. All right. Well, thank you so much. We'll make sure that you have that that form that you saw today, and we are really excited to hear more about it. And I hope that you all have a wonderful week. Thanks so much for joining, and we'll see you next time. Bye, everybody.